Hello guys, this is Medico on Run and welcome to my channel. Today we are studying the X-rays of ENT. What we have to present, first of all, whether it is plain X-ray or the contrast X-ray, and what is the region like a head and neck, mastoid region, nose and paranasal sinuses, soft tissue neck, view like AP view, lateral view, or you can say the Schuler's view or the Waters view, etc. Then after that, the anatomical landmarks that are visible on the X-ray, then you will tell the pathology and then you will tell the diagnosis. The first is the Waters view, in which you will see the maxillary sinuses. Now they will ask the questions in viva about the maxillary sinuses, like what is a volume? Volume is 15 ml. When did it appear? That is at the birth. And we can't see the posterior ethmoid sinus in this view. Differential diagnosis of the opacity in the maxillary sinuses are the sinusitis, malignancy, foreign body, teardrop sign you can see in the fracture, then antral polyp, then dental cyst, then bleeding from the orbital fracture. In this X-ray you will see the convexity. The convexity is present on both the sides, so it is a bilateral antral polyp case. Now साइनोसाइटिस में क्या होता है, देयर इज एयर फ्लूइड लेवल. वो जब एयर फ्लूइड लेवल है तो उसमें क्या होगा, जो एक्यूट होता है एक्यूट साइनोसाइटिस, उसमें देयर इज अ लेस एयर कंटेंट, व्हाइल इन द क्रॉनिक देयर आर लेस फ्लूइड विद इरेगुलर म्यूकोसा थिकनिंग इज देयर, व्हाइल इन द पॉलिप देयर विल बी कॉन्वेक्सिटी. Then these are the maxillary view, Waters view of the maxillary sinusitis. You can see you have to match it with the orbital opacity. Okay, so in this way you can see there is this one, a whole opacity in both the maxillary sinuses, so you can see the bilateral maxillary sinusitis. This is also the other one on the right side is one in which you will see only the one side opacity, so it is unilateral maxillary sinusitis. The next one is the Caldwell's view, in which we will see the frontal sinus most appropriately, and it is the frontal sinuses are normally asymmetrical and scalloped, and they are seen at the 6 years of age. There are the hostrations which is present, which will lost in the chronic sinusitis. The differential diagnosis can be osteoma, fungal sinusitis, or the foreign body. Like in this X-ray, the first one, you see the see the frontal sinusitis. You will see the scalloped or the hostrations which are present in it. The other is a submental vortex view, in which you will see the sphenoid sinus most properly. And the most important is that in the Waters view, the open mouth, you can see the ethmoidal sinuses also. These are the Schuler's view. Schuler's view is for the mastoid. It is 30 degrees cephalocaudal X-ray, in which the external auditory canal is over the internal auditory canal, and you can take the separate view for the right and left mastoid. Key areas are seen, that is antrum and the upper part of attic. For what thing we'll use it? We'll see the extent of pneumatization of the mastoid cells, mastoiditis, cholesteatoma, location of the sinus plate, and the tegmen. Now this is the Schuler's view. This whole you can see, this is the external auditory canal, and just below it you can see the temporomandibular joint, and the around this whole white thing are the mastoid cells. You can see there are three type of mastoid cells. First is the pneumatized, the second is diploic, which is pneumatized as well as sclerotic, and the third one is sclerotic. So in this case you can see the pneumatized ear cells on the left hand side, while on the right hand side you will see the diploic. That is, there will be the presence of sclerotic as well as pneumatized. Now these are also the view in which mostly you can see on now you can see the Sitterli's angle or the sinodural angle. You can see the tegmen plate, you can see the sinus plate. All these diagrams are properly explained in Dhingra. If you open the book and see all these things, you can properly see that. Okay, then you have to know this McEwen's triangle, you have to know the Trotman's triangle in the viva. All these stuffs are very much important. I'll tell you about all this later. Now we will see the Towns view. Towns view is there are very less chances that they'll give the Towns view, but they have given to me, so I want to explain it here. So in the Towns view, they'll ask what you can see in Towns view. The first is both sides temporal bone, you can see arcuate eminence, superior semicircular canal, mastoid antrum, internal auditory canal, external auditory canal, cochlea, tympanic cavity. Why we have to take the Towns view? We have to see the acoustic neuroma, for the apical petrositis, for the elongated styloid process, that is the Eagle syndrome. So in this one, you can see there is an elongated styloid process in the Towns view on the both sides. You can see in this there is a long process in between these transparent area. The long process is seen. Today my pointer is not working properly, so I'll tell you like that only. So this is the elongated styloid process. Then second is a mastoiditis. How will you differentiate whether it is mastoiditis or not? So in mastoiditis there will be diffuse haziness and the destruction of the intercellular septa, and then the lateral sinus plate is also more prominent. While in the chronic cases there will be diffuse sclerosis and the prominent periantral triangle. Now they'll ask what is the differential diagnosis of the cavity you see in the mastoid region. So you have to tell them there's a cholesteatoma, there's a post-op case, histiocytosis, large antrum, eosinophilic granuloma, TB mastoiditis, large emissary veins. Now I told you about this, so it is very important. That is the Satelli's angle or the sinodural angle. In the primary sclerosis cases, it is acute, while in the secondary sclerotic cases like CSOM, it is obtuse. So if they ask you whether it is a primary sclerosis case or the CSOM case, how will you differentiate? You will take the angle of the Satelli's angle. You will see the Satelli's angle whether it is acute or it's obtuse. Then you should know the McEwen's triangle. You should know all the boundaries of the McEwen's triangle, the tangent line, and then the the region of the upper region of the posterior auditory canal, posterior canal, and then the line joining both of them, temporal lines. You have to know everything. Then after the 12 to 15 mm deep has a mastoid antrum, and also it contains the spine of Hanley. Then the Trotman's triangle, superiorly there will be superior petrosal sinus, posteriorly there will be the sigmoid sinus, anteriorly there will be the solid angle. That is where the three semicircular canal meets. I didn't know this in my viva, so it's very important. They'll ask the boundaries sometime, and they'll ask what is the use of it. So it is a pathway to posterior cranial fossa from the mastoid cavity. Then comes to the next X-ray, that is a retropharyngeal abscess. So retropharyngeal abscess, they'll ask you, how do you say this is retropharyngeal abscess? So you have to tell them that it is more than half diameter of the second cervical vertebra. And the vertebra tum kahan se count karoge? You have to count from below, like 1, 2, 3, 4, 5, 6, 7, not from the above. And then you will also see the straightening of the cervical spine. Or if they ask what is the measurement, you can tell that in adults it is 7 mm at C2 level and 22 mm at the C6 level. If it's more than that, we can say that it's a retropharyngeal abscess. So the causes of the retropharyngeal abscess and the acute causes can be the adenoid, tonsil, trauma. Sometimes the foreign body also get infected into it. Then after that, the chronic are the infected lymph nodes. It's towards the one side and it is up from the base of the skull to the bifurcation of the trachea only. While in the prevertebral, we know it can be in the it is in the midline, and it actually starts from the skull, base of the skull, and then to the last spine. It will be there in the prevertebral cases, and the prevertebral cases is because of the tuberculosis or syphilis, like chronic granulomatous disease. Okay. Then what is we will see this adenoiditis first of all. So this is the next X-ray. In adenoiditis, how will you say? We will see in this lateral side there will be, increment in the adenoids tonsil. So we'll say it's adenoiditis. But they will ask you, how will you measure whether it is adenoiditis or not? So I have seen there's one yellow line there. So this yellow line is A, that is adenoid measurement. Distance from the point of the maximal convexity of the adenoid shadow to a line joining the anterior margin of the basi occiput. Okay, then there is this black line, that is N, and it is nasopharyngeal measurement, that is distance between the posterior border of the hard palate and the antero-inferior angle of the spheno-basi occiput synchondrosis. Now its ratio is 2. If it is more than 2, or it's, if it's if it's 2 or more than 2, you can say that it is adenoiditis. Now they will ask you what is the differential diagnosis of the nasopharyngeal masses. Then you will tell it can be adenoiditis, it can be juvenile nasopharyngeal angiofibroma, then it can be nasopharyngeal carcinoma, it can be dermoid cyst or the enteroquanal polyp. Now lastly, there is a foreign body. The foreign body in esophagus is actually seen flat in the or in the 2D, in the two-dimensional in AP view, while it is 1D in the lateral view. It's vice versa when the foreign body is present in the respiratory tract. The foreign body is mostly present in the esophagus only, but if it's present in the respiratory tract, you can see mostly it in the right bronchus, because it is in main alignment of the main bronchus. It is in more in alignment for the main bronchus. And the other are the other X-rays like the ecclesia cardia, in which you will see the beak appearance or the rat tail appearance, or in the carcinoma esophagus. Mostly they'll not put it in RGUHS, but they can be put if the examiner wants to put it. Then the last one is this tracheostomy thing. The tracheostomy thing is actually put there and they'll ask for what happened. So we have to tell that there's a tracheostomy tube was there and it got broken and it is presented as a foreign body. And point is this, that, in all the X-rays they'll ask you the treatment. Like in this case, what you will do, you have to remove this foreign body. In this case, you have to do the esophagoscopy, because this is in the esophagus, so you have to do the esophagoscopy. Then in this case, what you will do in adenoiditis, we will do what? Adenoidectomy. They can ask you the steps of the adenoidectomy, complications, etc. And then in this retropharyngeal abscess, you have to tell, we have to do the incision and drainage. And then after that, in styloid process, what you will do, elongated styloid process, you will tell styloidectomy we will do. And then in this the mastoid thing, they will ask you everything, that is the cortical mastoidectomy, radical mastoidectomy, or modified radical mastoidectomy. They'll ask you the canal wall up, canal wall down, all these surgeries they will ask, their complications, their indications. And in this maxillary sinusitis case, they'll ask how will you treat it. So you can say that it's FESS, that is functional endoscopic sinus surgeries, or they'll ask you different methods for the maxillary sinusitis. You can tell the Caldwell-Luke operation and all these stuffs, but Caldwell-Luke we don't use now. And for the Aquana also they will use, they'll ask for how do you remove it. So in this case also we'll tell it is by FESS only. So these are the things that they will ask you normally when these X-rays are given. Or you can study extra X-ray if you want to, I just told you, like carcinoma esophagus or the ecclesia cardia,